Welcome everyone. Hello, welcome everyone, and thank you so much for joining our webinar to discuss the 2021 campaign webinar launch. We're just going to wait maybe a minute or two here for everyone to funnel in, but in the meantime, if you will, I always like it when everyone puts maybe where they're from in the chat box, so feel free to do that. So we can see who's tuning in from hopefully across the nation and maybe even some people from around the world. But yeah, welcome everyone. Thank you again for showing up to our webinar. And we've got just a quick presentation for everyone tonight to kick off what is going to be hopefully an 8-week webinar series where we're going to be sharing patient experiences. So again, we'll wait just another minute here for everyone to get in. We've got tons of folks from Vancouver Island, Oregon, wow, Newcastle, wicked, from all over. Welcome everyone. Okay, well, let's stay true to the time here and get started. So thank you everyone who's in the waiting room, and Holly, I'm sure you'll be continuing to let people in for the presentation. So without further ado, let's get started. Okay, so first of all, I would like to make a quick land acknowledgement. Some beautiful Victoria today. The sun has been shining. It's been absolutely a glorious week here. And as I look around, I think it is really important to acknowledge that this Zoom conference is being conducted from Victoria, but that is the traditional, ancestral, and unceded territory of the Songhees, Esquimalt, and Westinish people. Okay, so for today's webinar, I would like to go through first and foremost the agenda. We're going to start off with a campaign introduction and give everyone updates on the Section 56 exemptions and approvals. After that, we'll discuss what is called a mandamus application, and that'll go over to our lawyer, Nicholas Pope, to discuss. Next, we'll go through a patient's perspective on exemptions. And we've got a patient, Jim, here, who's going to be speaking about his experience with the Section 56 process, as well as how some solutions may be presented. We'll also speak with a lawyer, David Wood, on a possible solution such as regulations and our proposed solutions around regulations. I'll final it off with the campaign schedule, discussing what we'll be going through over the next 8 weeks as we raise the voices of patients. And finally, share some ways that everyone can support and advocate over this next couple of months and weeks while we share patient stories. And finally, we'll thank our course for supporters and get to Q&A so that if anyone asks questions, they can ask us. So I'm going to start off with the campaign introduction and updates on Section 56. I realize that there are still supporters in this group, which means that there are patient supporters and people who have been supporting all of the patients and healthcare practitioners up until now who have gotten Section 56 access. Over the last year, about 34 patients and 19 healthcare professionals have been given Section 56 exemptions, and this has been fantastic. We've seen a ton of people get treatment, and many are waiting for treatment. There's a training program going on right now, and there are still people being supported both by our organization and by other organizations and doctors to get help through Section 56 and access to psilocybin. However, there are problems, and this is the purpose of this campaign, is we want to discuss the current problems with Section 56. And I think it's best manifesting itself in an understanding that as of today, we have 17 patients and healthcare practitioners, 17 patients, and I believe it's actually about 40 healthcare practitioners who have been waiting up to 5 months for a response to their Section 56 applications so that they can use psilocybin for treatment and for training. What I'd also like to acknowledge is that there is likely hundreds of other Canadians out there who have submitted Section 56 applications with the support of their doctors, they themselves, or through other organizations. And whereas I do not know the exact number, I have confirmed that there are many others who are waiting on these exemptions. Now, the purpose of this campaign and what I want to speak about today is why we're here running a campaign to support patients an entire year after the first Section 56 applications, and therefore psilocybin was granted to patients. And I think it boils down best into 2 main arguments for what we are working towards, which is a solution likely in the form of regulations. And those 2 main arguments are safety and equality. Safety, we want to make sure that patients get a safe supply of psilocybin and that they're able to do their treatment with trained professionals. And these trained professionals may be their therapists, their doctors, and nurses. And since we started our work at TheraPsil, safety has always been one of the primary concerns, making sure that people don't have to just go underground to get their treatment, but are able to do it legally with the help of their care providers. The second main argument would be equality. And equality is broken into a timely response for everyone, an equal response for everyone, and predictable access. Whereas right now, Section 56 is not timely. There's little known understanding of what the criteria are, which seems to be unequal treatment of who gets access and who doesn't. We want to make sure that there's a solution to this. So the campaign goal, much like the campaign that we ran about the same time last year, before the August 4th announcement that gave the first couple of patients access to psilocybin through Section 56, is to do what TheraPsil has been doing for about a year and a half now. And that is raising patient and healthcare practitioner voices as we seek a safe and equal solution to Canadians in medical need of psilocybin. Our goal is to work with government, not against them, to get these regulations. And really what we found the best thing that we could do was to make sure that all of those patients who are seeking access are heard and that they're heard loud. So next, I want to give an update for those who have heard about the possibility of court on what is called mandamus application. And so I'm going to turn it over to a lawyer that TheraPsil has returned to support a couple of the patients, Nicholas Pope from Hajdu Law. So Nicholas, over to you.
Thanks, Spencer. Good evening, everyone. So my name is Nicholas Pope. As Spencer said, I'm a human rights and administrative law lawyer in Ottawa at Hajdu Law. And we just today filed an application for judicial review seeking the remedy of mandamus with regard to a patient who applied for an exemption under Section 56 back in March and still hasn't heard back from the minister. So the first thing I want to say is what this court case is not, because I think there could be confusion around that. What it is not is we're not going to the courts to say that the minister must grant this person an exemption, because there's some discretion under Section 56, and that may be limited by Section 7 of the Charter, the right to life, liberty, and security of person. But that's a question for another day, and that may be litigated at another time, but that is not the question that we're bringing to the courts. What we're bringing is more of a procedural question. Here, the minister, 137 days after the applicant filed the application, still has not given an answer, hasn't said yes, hasn't said no. And so application for mandamus, it comes from the Latin for to command, and it's where the courts will put judicial oversight over the government, over the executive, and command them to do something that a law they're supposed to do. And we submit that Section 56(1) requires that the government give a response, whatever way that response goes. And Section 7 of the Charter also requires at least a response. And so we filed the application today and served it on the government. The next steps will be within the next few days. They should give a perfunctory response, just saying they'll show up to court, essentially. We'll be filing an affidavit with our evidence. And then what we're hoping is that this doesn't go to court. We're not looking for a fight here. It's a pretty simple application, and we're hoping that the government will issue the response. Whether it's a yes or a no is another matter, but at least issue the response just with this bit of legal pressure. And we've seen this in my practice happen numerous times in, say, prisoner transfer cases where somebody's requested a transfer from a US prison to a Canadian and the government doesn't even respond for quite a long time. And so then you file a mandamus application and then they finally give a response, whether yes or no. So that's where the case is at. We just started it today, but hopefully we'll be hearing from the government soon as to whether they'll actually issue a decision in this person's case.
Thank you so much, Nicholas. And to confirm here, for those, in case there's any confusion, as I'm seeing some questions come in, is is although there are a number of patients who have been given Section 56 access, it is for the patients who have been waiting months that this mandamus application will be put out for. So thank you very much, Nicholas. And next, I want to introduce everyone to Jim, and I think Jim's going to be able to speak a bit about regulations and a patient's perspective through the Section 56 journey. So Jim, are you there?
There, can you hear me now?
I can.
Wonderful.
Awesome.
My name's Jim Doswell. I am a 67-year-old dude who's got two different types of cancer, as well as anxiety, depression, and a fairly whopping good chunk of PTSD. My cancers are in remission, which means that, you know, I don't necessarily qualify for end-of-life treatment. My journey through this so far has been wonderfully supported by TheraPsil and by Anne-Marie, who I've worked with on my application for my exemption, and has been far less, I guess, lonely than it would have been had I not had the support of the society. I think we have to go the regulation route, because the possibility of trying to recreate something or to do something totally different, from my experience, and I spent a lot of years both as a chief federal negotiator for the government and assistant deputy minister at the provincial level, and a senior assistant deputy acting at the federal level, that the product of government is policy, and policy is reflected to the people as regulation. And if we are able to come up with regulation that the bureaucrats and mandarins and ministers can understand, we will come up with a potential solution. It may not be as quickly as any of us want. I can guarantee you that the government of Canada is currently in a freeze because of a potential election. There are people who will not be allowed to be creative at this time. So we do have some waiting to do. But it also takes time to get these regulations to the point where you want them to be. I believe that the minister is slightly outside her discretion, or greatly, but ministers don't always understand that both the Constitution and the Charter have certain impacts upon their ability to do things. And the current approach that the government is taking towards us is I think, unfair, in that people who have, say, cancers in remission, or severe anxiety, or severe depression, live every day with a sword of Damocles hanging over their heads. And it's not entirely different, although I would never, ever want to compare my situation to someone who is palliative. I would say that the pains are somewhat similar. And her discretion, I don't think, it exceeds that. So I'm hopeful that the work we do this summer will explain to Minister Hajdu that, you know, we all need hope. And we live in a country where the 13 out of 100 drugs that are most commonly prescribed are for anxiety and depression. And perhaps what we need to do is understand that mental illness is as serious as physical illness. And to deprive people of a known cure, which is safe, when done in a proper medical or clinical environment, is an amazing unfairness and discriminatory to probably hundreds of thousands of Canadian people. And that's all I have to say. Thanks, Spencer.
Well, thank you very much, Jim. I really do appreciate you coming and speaking here. I think it's a good time as well to thank you and all of the other patients who have been advocating so loudly for both yourselves and your peers, as it's not an easy thing to do, to come out here and speak in front of the Canadian public, and to, for lack of a better expression, sometimes air your dirty laundry in front of people. But it is about raising your voice and making sure that you're heard and that you're loud and that those who can't speak are heard. So thank you very much, Jim. I really appreciate that.
Spencer, as long as I don't have to leave the house, I do great.
Fantastic. Luckily, everyone's very used to Zoom over the last year, so
yes.
Well, thank you very much, Jim.
Thank you.
And next, I'd like to move this over to David Wood. David Wood has been working with TheraPsil for over a year now. And David, without further ado, I'll turn it over to you to explain a bit about what you do, who you are, and your legal view on regulations.
Yeah, thank you very much, Spencer. My name is David Wood. I'm a lawyer. I've been practicing as a intellectual property and regulatory lawyer since 2009. And I recently left a national law firm to take on a general counsel role at a contract manufacturer called Cygen Industries Limited, which will be manufacturing psychedelics. And I also run my own private practice for a very small number of clients outside of that. And my entire practice at this point, with one exception, is cannabis and psychedelics. When I was practicing at a major national law firm in 2016, I received medical access to cannabis and immediately put all my business development efforts into cannabis and gained a lot of experience working in that space. And then in 2018, had my first conversation with a client about psilocybin. And from there, the amount of my practice that was focused on psychedelics continued to expand until I joined a client working in that space. So that's me. My personal practice is intellectual property, including patent agency services and regulatory advice in cannabis and controlled substances. And I think regulations are needed here because I really believe that's what's best for patients. I think we need a regulated system that allows access to psilocybin for sure, and maybe one day other substances. But psilocybin, I think there's such a strong case in terms of its safety and efficacy evidence that I think it does make sense. And I know that Health Canada feels the same way to an extent because they've issued these exemptions. And I think much as we did with cannabis, although I think the outcome will be very different, this has started with exemptions issued under subsection 56.1. But as Spencer mentioned right at the start, safety and equality are critical here in healthcare. Safety and equality are cornerstones of Canada's healthcare system in general, and as they should be with any publicly funded healthcare system on the equality point. So I think that when you think about equality and safety, to me that boils down to predictability. Access needs to be predictable. And that means being predictable in two ways. So this goes to why regulations are needed. And that's that if we have regulations, and let's say something analogous to cannabis medical access regulations, probably most analogous to Part 14 of the cannabis regulations, which is the most evolved version of those, is we need a system where the choice of whether or not an individual Canadian who's suffering will receive psilocybin, that choice has to be in the hands of their healthcare practitioner, not in the hands of a government agency, of a ministry, because it's the healthcare practitioner's best informed to make that judgment call. I think predictability also means that the source and the quality and the nature and the amount of the product are certain and are the same every time. And so that the healthcare practitioners, as well as the patients, can understand what they're receiving when they purchase these products or however they receive them. They cultivate them themselves and understand that what they're getting will be what they think it is, which is not impossible with psilocybin, but more challenging in an unregulated environment. So that's, to me, what's important here. And those two things that are part of predictability, that the physician decides or the other healthcare practitioner decides on whether access is appropriate, and that the products are understood and are quality tested and are well defined and well labeled. Canada has a fantastic blueprint for that. Canada has regulated medical cannabis since 2001 and has regulated it in a multi-participant commercial industry since 2013. So what that gives Canada is experience regulating a very unique class of product, because cannabis products are not drug products, they're not food products, they're not tobacco products, they're not vaping products, they're not cosmetics, they're not food products. I might have said that one already, but they kind of look like all of those. And that's why cannabis, which is a product that is used therapeutically, is also used not therapeutically, but that's not what we're focused on here. Cannabis is used therapeutically. It has an active ingredient. Cannabis products are labeled for those active ingredients. And cannabis products can be in a few different classes: dried cannabis, cannabis extracts, edible cannabis. It's pretty easy to see analogy to dried fruiting bodies of psilocybin mushrooms, edible products with psilocybin in them, psilocybin extracts for eating, not for vaping. And then psilocybin extracts would probably include synthetic psilocybin, because unlike cannabis, now the science is far from final on this, but to a large extent, there's evidence of significant efficacy and safety of psilocybin alone. I'm not disparaging or, dismissing something that comes from the whole organism, from the whole fruiting body or mycelia that is more than just psilocybin. But in this case, unlike cannabis, I predict that we're going to see a lot of preference for pure compound. That's just my personal view, alongside fruiting bodies. But in either event, Canada has experience regulating this class of product that has an active, is available in a few different classes, and is available therapeutically, yet does not have a health claim and isn't a drug product regulated under Part C of the Food and Drug Regulations. We have that experience, and we are currently doing that under the Cannabis Act. So I think Canada has not only the experience preparing these regulations. I mean, here's a copy of the cannabis regulations, very similar system. It'd be shorter, thankfully, for psilocybin could apply. Canada also has the administrative experience to effectively administer those regulations and can probably have a lot of cost savings relative to any other country that might attempt this on watching the amounts of psilocybin products being produced, watching where they're moving, who's buying them, which provinces, et cetera, all of which may be useful for our work with the UN and maintaining our compliance with UN drug conventions. And on that note, nothing that we're proposing involves a change to any act of Parliament. What we're proposing would involve new regulations and amendments of certain aspects of the Food and Drug Regulations, but would involve no changes of any kind to the Controlled Drugs and Substances Act or to any other act, and would be consistent with Canada's UN obligations. I'll finish. My last point is that the science here, and I have a PhD in biochemistry. I do understand the scientific method. However, I'm not out there directly innovating the way scientists who are scientists and only scientists would work. So my experience here is informed, but not a working knowledge. But on my understanding of evidence that's been gained with psilocybin through clinical trials is that there is significant evidence of safety. David Nutt's work shows that. Many other journals have shown that. And there's evidence of efficacy, and there's too many to count there. So I also predict it'll be used in maybe a bit of a different way than cannabis, because there have been criticisms of the medical cannabis system that I don't think would apply when the amounts being accessed by Canadians are relatively small and for a relatively limited number of psychotherapy sessions. However, want to emphasize that what TheraPsil is talking about are federal regulations that would regulate primarily two things: how Canadians get access, similar to Part 14 of the cannabis regulations, and what they get access to, as in what would be required, what would be prohibited on psilocybin products in terms of ingredients, classes of psilocybin, et cetera, and also in terms of labeling, safety measures, tracking. So at the product level, the federal government would regulate this. The federal government could create rules under which it can be accessed, and that would probably be based on a medical document, much like cannabis access. But the provinces and their healthcare practitioner colleges would have the most control over who and under what circumstances writes a medical document. So that's everything I have to say here. That's my possible solution, TheraPsil's possible solution, not mine, ours. And I just want to say that we can. You know, Canada, we have experience doing this. We've regulated cannabis as a therapeutic product without an indication for the last 20 years. We can do this with another controlled substance that is safe as you can. There's no such thing as a safe drug, but it has a strong safety profile, and that there is strong evidence of efficacy, and that I think the substance itself could be remarkably cost effective in treatment, especially when you consider how fast people may be going back to their ordinary lives, whatever that means, and using fewer resources in the healthcare system. And I think it's got a low risk of harm to people, on my understanding, if it's used properly. And I also believe that the administrative cost here will be mitigated by all the experience Canada has regulating and tracking and monitoring the cannabis industry. So there is no country better positioned to do this. And I, for one, really hope something like this can happen.
Wonderful. Thank you so much, David. I really appreciate that. So there's just two things that I want to comment on as well, David, that you mentioned. And that would be that we've done this before. And there's two things that we've done before. One as a nation is we have realized the rights and actualized the rights of Canadians who, under Section 7 of the Charter on Rights and Freedoms that would give them life, liberty, and security of persons. And I believe that's been seen as the right to make their own medical choices and to have access to their medicines. We've seen that play out before, and we've seen that the government is not allowed under Section 15 to discriminate against patients based on mental or physical disabilities. My hope is that through running this campaign and through supporting patient and healthcare practitioner perspectives on treatment access and regulations, that we're able to work with the governments. And so, Nicholas, as you said, the goal is not to fight the government, not to take them to court, but to show them that we're serious, that we do want to support patients, and that patients and healthcare practitioners are fully able and willing to support themselves too, making sure that voices are heard and that they're heard loud and clear. It's unfortunate that so much effort is required here to get a response from the minister, Patty Hajdu, and from Health Canada. But a response is due and a solution is due that does fully exercise our charter rights and the rights to every taxpayer who pays into Health Canada and who is part of this public healthcare system. So I guess I'll weave that into here. Why we're sharing the patient stories and how we're going to be doing that is just like last year. What we did that worked very well was sharing the plights, the stories, the success stories of patients and healthcare practitioners who had access to psilocybin and who would like to. And we'll be doing that starting off with week 1, which is starting this week, with our first webinar on Wednesday, and week 2 next week, where we will be looking at psilocybin therapy in palliative care. So the first cohort of patients who were given access, and we'll get some patient perspectives on how their treatment went, what it was like, problems around access, and why regulations may be able to help them. In week 2, that will be the 1-year exemption anniversary. So it was August 4th of 2020 when the first exemptions were granted. And we'll be looking back and forward to an equal and safe access to psilocybin. Again, sharing patient stories as much as possible throughout the week with different letters and webinars and videos coming out. Week 3, we will expand the scope here as when we talk about equality and start to look at how access to things like cannabis has been much broader than just palliative patients. We'll look at some other people who are using psilocybin, and I do know that there is a rich community of veterans and folks with PTSD who are using psilocybin for treatment, as well as patients who have been treated with psilocybin for a palliative diagnosis to see resolution in their PTSD. Week 4, we will be focusing on substance use disorder and psilocybin therapy and the urgent need for regulation changes to help many people who are struggling with addiction and substance use. And then week 5, 6, 7, and 8, we will be announcing that there will most likely be stories of people who have used and who are seeking to use psilocybin for things like eating disorders, depression, anxiety, and chronic pain. We're also going to be sharing the fact that we are launching a public fundraiser. So we, of course, would ask that at every part of this campaign, if you are ever able to donate, that you do. We are a nonprofit. We are publicly funded, and we were actually very graciously supported by Dr. Broners. So any donations, any $50 donation does get you one of these awesome 4-ounce bottles of soap. But of course, more importantly, those proceeds go to supporting this campaign and future campaigns like it so that we can get to regulations. But we need your voice, and we hope you can advocate with us. This conference, this webinar, is us, TheraPsil, and healthcare practitioners, patients, and members asking you to join this campaign and webinar series, as it is attention that is going to get Patty Hajdu's attention, our sharing of these videos and of the stories of patients. Just tweeting and tagging Patty Hajdu or sharing these videos and webinars on Facebook really is enough to make change here and to get the government's attention. You can also write to your MPs, and more will be coming this week on how you can do that using some tools and some help from TheraPsil. And you can also become a TheraPsil member if you're interested. I also want to say thank you to the many supporters that we've had, a couple of industry supporters who have given significant amounts to make this all possible, such as Nikean, Cygen, MindCure, Apex Labs, Dr. Bronner's, Optimum Health. Without further ado, we'll get Holly in here. I believe Holly has been writing down questions from the audience throughout this call. So Holly, I'll put it over to you, and you can direct questions to myself, Jim, Nicholas, and David.
Awesome, thanks.
And thank you, everyone.
Spencer, do you mind stop screen sharing? Just, yeah, so we don't need to be on the question.
You bet.
Awesome. Hi, everyone. Hope you're doing well tonight or this afternoon, depending on where you are. We got a lot of great questions in the chat, so I'm just going to riff through them and hopefully we can answer them all. So the first one I'm going to direct to Nicholas, if Nicholas is still on the line here, and it's regarding the mandamus application. So with the mandamus that you were talking about, would this change things so that the minister must respond to all exemptions currently in the queue with either a yes or a no, or only to the individuals mentioned in the current mandamus?
Cut out there for a second, but I gather that you've asked whether the mandamus application will apply to everyone or just the one person.
Correct.
Just the one person. However, the government, if it's very unlikely they'll want to waste resources with lawyers and receiving a whole ton of these applications if they capitulate on this one, or if we win in front of a judge on this one.
So as a follow-up question, what would you say is kind of the long-term effect of doing a mandamus? Is it really just setting a precedent and showing the government we're serious, or what's the point, I guess?
I think it is just showing the government that we're serious, showing them that they can't just delay, and in effect give a no decision without having to actually give a no. So hopefully in the future, they'll realize, let's say our applicant here, maybe they say, okay, yes, we know we have this legal obligation to render a decision, they render it, but then they'll be less likely to drag their feet on everyone else, knowing that there might be another court challenge coming their way.
Great, thanks, Nicholas. This one's for Spencer, potentially with an assist from Nicholas. So Is the mandamus on behalf of a patient or patients only, or does it include the 40+ therapists and healthcare providers who are also waiting for access via Section 56?
Yeah, and I think I can comment, Nicholas, here. So this is, again, for a single patient, but the idea is to set a precedent, right? And to show, I mean, from my perspective, how ridiculous it would be if the only way to get access would be spending money to get a mandamus application put together. Again, I think we're trying to prove a point here, which is we can do this. We could put mandamus applications together for every patient, every healthcare practitioner. And what we would be seeking is a response from the government that is fair and equal and consistent with our charter rights and how previous patients and healthcare practitioners have been treated. And in these instances, I mean, there have been other nurses, doctors, other patients in remission for cancer, along with those with an active diagnosis and who are currently palliative, given access. So as I would understand it, would be what would change, right? Why would be the purpose of doing a mandamus for everyone when we can just kind of put our best foot forward and say, well, let's start off with one. So I hope that answers the question.
Thanks, Spencer. I'm going to open this up to everybody on the panel. So do you have any thoughts on why the minister might be saying no, or saying no by way of just not responding? Do we think it has anything to do with the upcoming election, or what are the thoughts behind the fact that individuals just aren't getting a response anymore? Anybody care to share their 2 cents on that? Oh,
Jim, I think you're muted. Why don't you go for it, David, and then Jim, if you want to. Yeah. I
think we got you.
Unmuted. Oh, David. Yeah, go ahead, David.
Well, I hope I don't deflate whatever you were going to say, because I was just going to point out that it's often, there can be so many reasons for why a regulator is behaving in a particular manner that I think it's, and there are many examples of this in cannabis. It's very difficult to understand why without talking to someone there who just tells you. And that's, outside of anything like that, which shouldn't really be happening anyway, it's just very difficult to really understand why. And that's why I try not to conjecture. I try and move things in a way that I think will just help us the most. I try not to read too much into those kind of things. So I hope that doesn't deflate your point. But with that, why don't you let us know what you think, Jim?
Well, and you'll have to excuse me after this. I'm going to run because my sister, who I've not seen in over 1.5 years, is sitting in my living room, and I would really like to visit with her. Doing nothing is the easiest thing in government. And so the minister is doing what she does best. And the way that things get done in Ottawa, quite often, my experience is both inside the system and outside the system, is when it becomes a little too uncomfortable to do nothing. Now, for the next 6 months, I think we have to expect that everyone in Ottawa is just thinking about how they're going to get reelected and how they're going to get their pensions, and that's okay. But that is the way the system works. It tends to freeze before elections. Senior civil servants are instructed not to do anything, not to make any public statements, not to advance any issues that may be controversial to the government. But I think that's also a wonderful period where we can make this maybe a little bit more controversial for them. We also should be watching very carefully what happens in the United States, because sadly our government has a hard time kind of walking forward without seeing what happens in the United States. So what is currently taking place in California and Oregon and other states is going to be very critical to what we want to do here politically. And at the end of the day, in Ottawa, all things are politics. So But I thank you, and I want to thank you, Spencer and Holly and Nicholas and David, for allowing me to be on the panel today. I really appreciate it, and you know, and for everyone who's tuned in, and that I'll keep working as hard as I can together with TheraPsil to do what we can to maybe change this stuff and have a positive outcome. And love you all. Take care.
Thanks, Jim. Take it easy.
You too, man.
Okay.
And I'll jump in there, Holly, and just add one bit too. And really, like, I hope this is a bit of a call to action for everyone on this call, and we'll be doing it for the next couple of weeks. But it really is, as Jim said perfectly, the government's position to do nothing until it's too uncomfortable. And that is what happened last year. I mean, it was quite literally patients, people like Jim and Thomas Hartle and Lori Brooks, you know, being brave enough to put videos together and share them, right? Explaining what they're going through, how difficult it is, and why they want access to psilocybin. And that's only half, because the other half was people such as the folks in this call right now, and all of the other Canadians on Facebook, on Twitter, who took to emailing their MPs, to emailing the minister and writing letters and supporting, saying that I'm not going to stand for this. I think something that's interesting here is, you know, yes, there's doing work for yourself, but in Canada, when it's work to change a healthcare system, it's inevitably doing work to change it for you and all of the other people around you too. And so who knows who may need access to psilocybin one day, or if this was, you know, another medicine, how the government might respond. And I think that we should hold our politicians, people like Patty Hajdu, people at Health Canada, whose job it is to listen to patients and make sure that we're pushing forward policies that are making medicine safer and more equitable. Like, that is their job and the reason we pay taxes. We should hold them to it. And I think that sometimes it's unfortunate but necessary to put public pressure on them to share the voices of patients. And so I really do thank everyone who's here. And I do see that as the solution, is exactly what we're doing here, and what we will be working with everyone to do over the next couple of weeks.
Well said, Spencer. Thank you for that. Back to a few questions. So this one might be for David Wood, maybe an assist from Nicholas, a bit from Spencer. So there's been a couple questions about the SAP, which for those of you who don't know what that means, it's a special access program. So I'm going to kind of parcel this up. First, can somebody explain what the SAP is? Is the SAP a suitable solution to this problem of Section 56 is not getting approved? And if anybody has seen the recent kind of notice that Health Canada put out, I believe it was 3 days ago, about their proposed changes, nothing set in stone. Does anybody want to comment on that? So I will, who would like that?
I'm happy to. Nick, did you want to speak first?
You got it.
David.
Okay. So there's, and I've spoken with many people that confuse these two concepts. So just what they are, a subsection 56(1) exemption is an exemption from any provision of the Controlled Drugs and Substances Act for a specific purpose and to a specific extent. So I'd say the most common type of subsection 56(1) exemption that's issued is a research exemption, where a university or other researcher wants to study a controlled substance for whatever reason. And to conduct that study, it will be necessary to possess the controlled substance and to source it from somewhere. So in the ordinary course, the researcher will file an application that says, here's how much I want of this controlled substance for this experiment. Here's who I will get it from. Here's how I will make sure it doesn't get stolen. Here's who will have access to it. You just kind of tell them these things, and you'll name a licensed dealer that you're going to purchase it from. Because there is no such thing as an illegal drug. All drugs are just drugs. Some of them are controlled substances, and without an authorization, it is contravention of the Controlled Drugs and Substances Act to possess them. But you can't really say the drug is illegal. The way I look at it, treason or murder are illegal. Controlled substances are just controlled. And an exemption exempts whoever holds it from application of the Controlled Drugs and Substances Act consistent with the exemption. So the medical exemptions that are issued are not your typical exemption, because usually exemptions are for research, such as clinical trials, any clinical trial besides authorizations under the Food and Drug Regulations to do the trial, like good clinical practice compliance and research review. A subsection 56.1 exemption, it would also be necessary for them to possess the controlled substance if the trial was on a controlled substance. So in this case, a few exemptions have been issued for Canadians to possess and consume psilocybin for therapeutic purposes, much like they were issued with cannabis in the late 90s. That is different from special access. Special access, and as Holly pointed out in the question, it doesn't currently include restricted drugs, of which psilocybin is an example, but it might. And that's what Health Canada's proposal was in December, was to allow restricted drugs to be accessed through the SAP. The SAP was designed for, let's say, rare, often expensive treatments for likely rare conditions where the particular drug, maybe for a particular type of cancer, isn't available in Canada, but is available in another country, or is very close to being available elsewhere or in Canada under clinical trials. Through special access, a doctor can say, "Dear Health Canada, I would like my patient to have special access to a drug product," and that's an important concept here, a drug product that is currently not available in Canada. I've identified the manufacturer. I've said why I think my patient needs this. Please give me access. So that's a little bit about what each of them are. Now, to just give a brief side-by-side comparison here, under an exemption, the grounds for letting someone possess a drug can be whatever the minister thinks is appropriate. There's no constraints on that. The service standard is 45 days. You apply for an exemption. TheraPsil's seen it much, much quicker, particularly where the person does not have much time left. But we've also seen some well past that number that TheraPsil, I'm sure many others have filed. So while that's a service standard, the minister can't really be held to it. So the exemption can be for any purpose at all. It has no particular timeline it happens on, and it's completely discretionary. They can accept it or reject it. The other thing is that there are no particular standards that need to be applied to the psilocybin. It can just be sourced from wherever. There isn't a source given in the exemptions that I've seen. So what that means is the psilocybin that's going to be possessed and used under an exemption has absolutely no safety standards, no production standards, no standards of any kind applied to the product. If you want to sell a cannabis product or a drug product or a food product or a tobacco product or a vaping product or a cosmetic or a natural health product in Canada, there are rules about manufacturing standards. There would be none under an exemption that definitely apply. So it could be just a pile of fruiting bodies that the person eats, and we have no idea what the percentage of tryptamines in them is, and we have no idea how safe they are. Special access, on the other hand, only applies to drug products that have an indication but aren't available in Canada. And special access only applies to drug products that are going to be manufactured in compliance with a standard that, Health Canada is comfortable with. And based on a Health Canada webinar, because this isn't the law, this is just kind of their policy on how the law is applied. So this policy can change at any time. But according to their webinar, they look at late stage drugs that are almost approved in another country or already approved in another country. And that's kind of the realistic bandwidth for special access. So it's very different than what would be available under an exemption. It's much narrower, but it's going to be something that's better characterized. The system that we're proposing would be much closer to that standard than to the zero standard that applies to an exemption. That said, an exemption could say you must source GMP psilocybin. It could say you must source fruiting bodies grown at a licensed dealer. It could do that if the minister decided. But that's the thing about exemptions, they can say anything, whereas special access has defined criteria. And the last thing I'll say about it is with special access, there is a test, and I'm not going to even paraphrase it because I'll butcher it, but the test relates to whether other therapies have been tried and or are not suitable and aren't available in Canada. I suppose this is the last point about it. Special access has a service standard of 24 hours. So in that respect, it's much better, but it's going to only be available for drug products that are partially through regulatory approval, whereas exemptions could be any controlled substance.
Awesome. Thanks for that thorough answer, David. I always learn a ton when I'm listening to you, so I appreciate that. I hope everybody else learned a thing or two as well. We had a lot of questions come through. I'm trying to parcel them up so we hit all the main points, and we have 8 minutes left. So this one, so somebody asked about, are there limitations attached to the application? For example, palliative use as opposed to the treatment of addictions. So I'm going to kind of rephrase this and say, what is the criteria that the Minister of Health is using to say, person A, you get an exemption, person B, you do not? And what kind of exemptions have we seen that we've supported that have been approved and those that have not been approved? And I'll let Spencer take this one.
Well, thanks, Holly. And I want to make clear that one thing is the minister has not yet said to anyone, you do not get an exemption. And again, this is part of the issue and why we're bringing the mandamus application forward. Is one option, as Jim said very well, the government is delay. Don't give a yes or a no. And I think that's important here, is they have not said no to anyone. However, as for the criteria, that too has been quite arbitrary. We don't necessarily fully understand it. When the first couple exemptions were coming out, it was pretty much yes to everyone. And we were focused on patients who, much like the research, either had a active palliative diagnosis or were in remission. And that's when we saw many patients who were currently terminal get access, as well as other folks such as Mona, who's working with TheraPsil and has made her story public, them get access as well. And those are people who are in remission. However, what it seems like today, just from what I can see anecdotally, is that really they're focusing more on just those who are the most palliative. And so in some cases, I mean, I will pay the dues to the government, is some patients have had access in as little as 24 hours. If we write a message saying, this person doesn't have much time, they have been incredibly responsive and getting an application like that. However, for many other people, it is quite unclear, right? What is palliative enough, or what is the criteria? And having a politician or a bureaucrat decide this is different than having it clearly and predictably written out in legislation. So the minister does have the ability to use her discretion to say who gets access and who doesn't. But certainly what we can do as Canadians is say that we have a Section 15 right, that everybody has equal treatment, benefits under the law, and not to be discriminated against based on age, race, or mental or physical disability. And this really is the problem, is that we don't know what's happening. Is this discrimination based on indication or something worse? And the way we protect ourselves from this is having a clear piece of legislation that puts that decision not into the hands of a bureaucrat or a politician, but in the hands of a doctor, right? The person who understands the patient and is able to make a reasonable choice or a reasonable suggestion as to what that person should be trying. And David, feel free to or Nicholas, feel free to add anything to that if you think it's necessary.
Okay, I'm going to say no additional comments are required. Yeah, and so I do want to clarify a point, because for those of you who've been following along with the TheraPsil journey for the past year now, you've seen that we've primarily focused, solely focused on palliative individuals, those with a terminal illness, and those in remission from cancer. For those of you who follow us on social media, you may have seen that an individual diagnosed with ALS was recently granted an exemption, which was the first time that the minister has granted an exemption for an individual other than with terminal cancer or with a active or in remission from cancer diagnosis. So there is some progress there, but to be clear, when we're talking about regulations and wanting to move this forward, we're really talking about for all Canadians in medical need, whether that is somebody who is suffering from a substance use disorder, from cancer-related anxiety, cluster headaches, other treatment-resistant health conditions, treatment-resistant depression, treatment-resistant anxiety, etc. Again, we're looking at this to be in the same position as medical cannabis, for example, where the decision to access psilocybin therapy is one made between a patient and their healthcare provider, not between a patient and the highest levels of government, Minister Hajdu. So just want to clarify that although up until this point, we've been so narrowly focused on those in palliative care, we're really here now rooting for everybody, because we don't believe that there should be, the Minister of Health saying this person's suffering is more or less than this person's suffering. That's really not her decision. So 3 minutes left, got a couple more questions.
Holly, could I add to that just briefly?
Absolutely.
It's also important to recognize that the federal regulations we're proposing do not get into why someone should be given medical access. That is up to a professional, and that professional is regulated provincially by their college and by applicable law in the province. We simply want to make a mechanism where that professional can say, my patient needs psilocybin, I want them to get this product from this provider, or maybe that's the patient's choice. And I think it's important to recognize that the regulations we're proposing leave room for a lot of different classes of psilocybin. So if I made a comment about synthetic, I think there's reasons that might be preferable in some cases, but I also predict that in a situation where psychotherapy acceleration is the goal, if someone relates better to dried fruiting bodies or something made from dried fruiting bodies for whatever reason, at a certain point, that has to be recognized as relevant to the outcome, because probably part of the crucial setting is the class of psilocybin the person's consuming. And if that person has a belief that might increase the efficacy of fruiting bodies relative to a synthetic compound, I'd hate to rule that out when the safety is going to be comparable. Again, thinking about a substance that has a remarkably strong safety profile.
Yes, fantastic. Thank you, David, for clarifying that. Okay, there was an individual who's a healthcare professional on the line, a family doctor, who's wondering currently if they have a patient who is looking for access, but that patient is dealing with refractory depression that passes basic exclusion criteria, how would that individual get assistance, at this date and time? Spencer?
Yeah, sure, and I can answer that. So TheraPsil is a small organization. I mean, we've got at this point in time one nurse who's working on patient intake, and I think that I'll just comment on something that's really important to understand. Although looks like there's only 16 patients waiting for access, that's simply the number of patients who we've been able to support with the funding we have. The true number is much larger. That is thousands and thousands of people like this patient who have been reaching out to us asking if they can also get support for a Section 56 application. And what we've had to do is focus on clinical acuity, really, is who needs it the most. And really, it seems hypocritical, right, of the government. And this is why we want regulations, is we don't want to be the bottleneck deciding who gets access and who doesn't. Which is why we're opening up the inclusion criteria and supporting folks who have PTSD, supporting folks who have cluster headaches, who have anxiety and depression. The only problem is it's very difficult to do that in the numbers that are necessary, because when we think of who's messaged us in this similar situation, who would not currently meet the criteria, the answer is there are hundreds and hundreds, maybe thousands of them. Which is again why we're doing this campaign. Is at this point it's almost futile to be supporting individual exemptions. And what we need to be doing is focusing more on creating a fair and equal system, so that those patients and doctors can get the access granted to them, so that doctors can do training, and so that in a way we're not needed. That is the goal here, is make sure that there are regulations. So I hope that answers the question. It would be unfortunate. I couldn't promise that we'd be able to get in touch with that person and to put forward a Section 56. But I would say that we're doing our best to speak for them and speak with people like them through this campaign.
Thank you, Spencer. I'm a stickler for time and we're 1 minute over, so I'm going to compassionately draw this to a close. There was a few questions that were unanswered, and I'm very sorry if we didn't get to those. If that is still a burning question, you have a couple options. You can email us at info@therapsil.ca, or you can show up to our next webinar, which is happening on Wednesday and every other Wednesday after that for 8 weeks, maybe longer, depending on how much we need. So with that, I just want to thank all of our panelists, David, Jim, Nicholas, Spencer, everybody who showed up this afternoon or evening. And Spencer, I'll leave it to you for a close.
Yeah, and I'll just thank everybody who showed up here as well. Really, you know, Health Canada, the governments, the bureaucrats, everyone who works in it works for all of you, the taxpayers, patients, healthcare practitioners. And what we're doing is not the first time, you know, this has been done. Public advocacy, it works very well. So really, thank you everyone who showed up, and for those of you who have supported and will support and continue to, you know, make sure the patient voices are being heard. From the bottom of my heart, and everyone who I work with, thank you.